From the American Neurological Association, I'm Adeline Goss. This is ANA Investigates. This year, the American Academy of Sleep Medicine published updated guidelines for the evaluation and treatment of restless leg syndrome. There are some big changes in there for the 2 to 3% of the population affected by RLS, including a recommendation against dopamine agonists. Here to discuss those changes is Dr. John Winkelman, Chief of the Sleep Disorders Clinical Research Program at Massachusetts General Hospital and Professor of Psychiatry at Harvard Medical School. Dr. Winkelman was interviewed by Dr. Kara Wyant, Clinical Assistant Professor of Neurology at the University of Michigan. Here's Kara.
Welcome, John. It's really great to have you here today.
Thank you so much, Kara.
I was wondering if you could start us off by briefly highlighting for our listeners what changes were made in the guidelines published in January compared to the prior guidelines from the American Academy of Sleep Medicine in 2012.
Well, Kara, it had been 12 years since the American Academy of Sleep Medicine had released practice guidelines for restless leg syndrome, and a lot has happened during those 12 years. So it's not a surprise that the guidelines recommendations have changed. The biggest, splashiest change is that dopamine agonists, which have been the go-to medication for 20 years for restless leg syndrome, are no longer recommended as standard treatment for RLS. It's also become increasingly clear that iron supplementation is helpful, not for everybody with RLS, but for many people with RLS, whether it be oral iron supplementation or intravenous iron supplementation. Similarly, now there's been additional data for the gabapentinoids, also known as the alpha-2 delta calcium channel ligands, with an FDA-approved drug among those, but there are 3 options in that class. So things really have changed quite a bit, and it's been quite a bit of time, so it makes sense that they've changed.
Yeah. So, can we start by talking a little bit about the evidence that led to the shift towards the iron and alpha 2 delta ligands?
Well, in the intervening time, a new alpha-2 delta agent, gabapentin enicarbal, which is a gabapentin prodrug with a controlled release formulation, had a variety of phase 3, phase 4 clinical trials come out demonstrating its efficacy. Similarly, a trial of pregabalin versus pramipexole was published in the New England Journal of Medicine. I was senior author there, demonstrating equal efficacy. And gabapentin has less robust evidence, but given the consistency of the mechanisms of action, we included that as strongly recommended. IV iron formulations have had a couple of phase 3 trials demonstrating their efficacy in individuals with iron indices within a certain range, i.e., generally ferritin less than 100, transferrin saturation less than 20%. Those have demonstrated efficacy in placebo-controlled trials, both with 2 different kinds of IV iron. PO iron also has evidence for its efficacy there in a trial with patients with a ferritin of about 40. So the evidence is pretty strong for these interventions having efficacy in RLS.
Excellent. So now let's shift to the dopamine agonists. So this shift away from dopamine agonists strikes me as potentially controversial. And please correct me if I'm wrong, but these medications still seem to be in widespread use for RLS. What evidence led to that shift away from the strong recommendation for certain dopamine agonists in 2012 to the recommending against their long-term use in 2025?
Sure. Make no mistake about it. These medications are extremely efficacious in the short term. I was the first author on the pivotal trial that led to the approval of pramipexole. That paper came out in 2006 in Neurology. Really good data. Unfortunately, it was a 12-week study for a disorder, restless leg syndrome, that for many people is going to be chronic and lifelong. That kind of discrepancy is unfortunate. And I have to say, I was naive in thinking that short-term efficacy is the same as long-term efficacy. What we've now learned is that over the long term, these medications, the dopamine agonists as well as levodopa, are associated with this phenomenon called augmentation, a worsening of the underlying RLS with chronic use. Even in the low doses that are used in restless leg syndrome, we know you get dyskinesias, on-off phenomena with these agents in Parkinson's disease. Here we don't get different kind of movement disorder. We just get a worsening of the underlying original disorder such that individuals have an earlier and earlier and earlier onset over a matter of years. Initially, they had 10 p.m. onset. You gave it at 9, they were good. Then within a few years, they're having a 6 p.m. onset. So you give it 5 and 9. Then a few years later, they're having it at 2 p.m. or noon. Now you're really stuck. And as Will Rogers said, if you find yourself in a hole, stop digging. So there's now substantial evidence that the incidence of augmentation is somewhere around 7 to 10% of patients developing augmentation per year. 7 to 10% per year. Doesn't sound like a high number, but if somebody's taking them for 10 years, we've got at least 50% of people who've developed augmentation and now have symptoms much of the day, have to stand at work, have to pull over on their drive home from work, can't relax in the evening, and they started off only with symptoms in bed. And once it develops, it is significantly problematic for the patient, but also it's very, very difficult at that point in tapering them off these medicines because every small dose decrease leads to a dramatic increase in symptoms. I would imagine that most of your listeners have seen this in their patients, and they weren't exactly sure what to do or what it was, and they just kind of kept increasing the dose, little by little, throwing more gasoline on the fire of RLS. But there is an alternative. We have these strongly recommended medications at this point. You can't just switch over to them because that doesn't work. Tapering these medicines, the dopaminergic medicines, has to be done extremely slowly over 6 to 12 months with the medication that's being used to replace it on board. So it's not easy, but it is certainly well worth the effort. I did develop a free, non-commercial, HIPAA-compliant platform called RLS Curbside that all you have to do is be a provider, register on the site, and you can describe your patients in a template that's provided, and a variety of other providers across the United States give advice on how to manage this. RLS Curbside is very valuable, I think, for difficult RLS patients. And as I said, it is no commercial influence, is free, and we don't get paid for using it, any of us who respond to it. It's just helpful.
So that's great. So it sounds like there's been a large educational effort as well as support systems in place now in order to help change practice. Do you think patterns of using dopamine agonists for RLS differ between neurologists and non neurologists, or between general neurologists and specialists in movement or sleep medicine?
Yes, I do. In fact, that paper that came out in Sleep 2 years ago with the drug utilization data from 90% of all providers in the United States demonstrated that neurologists were much more likely to prescribe dopamine agonist doses for people with RLS. Everybody with PD was excluded. Just for people with RLS, much more likely to use doses that were above or well above what the FDA recommends as the maximum dose. It makes sense. Neurologists are used to using higher doses in PD, But in RLS, those are inappropriate. And it may be that they're getting more complicated patients and inheriting them and therefore starting off with these higher doses. But neurologists are a very important target, I would say, of educational opportunities. I was just at AAN in San Diego giving a plenary talk on the changes in these guidelines. And I do think neurologists do need to understand the severity of augmentation with the dopamine agonists and change their practice. And this will happen over time.
So I think that this is a really interesting example of a gap between the evidence and clinical practice. It seems like there has to be a certain level of evidence of benefit for a new state in order to shake people from their current status quo, motivate them to unlearn a behavior and relearn a whole new one. So, multiple steps within that. Do you think that we have the necessary level of evidence in RLS to drive this major shift in practice?
Yes, I do. There's no doubt that we have the necessary level of evidence. How to communicate that to the providers across the US is unclear. The main issue is that dopamine agonists are so effective in the short term. They're just fantastic in the short term. The honeymoon period is wonderful, but over a matter of years, this wonderful relationship fades. And then it becomes harder and harder to dig oneself out of this bad relationship. And I think providers need to examine their patients, ask them about worsening of symptoms. It's just changing practice incrementally, asking the questions, because of course we know in medicine, if you don't ask, you don't know. And if you're not asking patients about their 24-hour distribution of symptoms, you won't find out that they're now starting 10 hours earlier than they did before you started prescribing. So how best to change practice? My approach is just to communicate the evidence and hopefully change one person's practice at a time.
So I want to shift the conversation a little bit. One other potentially surprising recommendation for the new guidelines was in favor of these extended release oxycodone or other opiates in the treatment of RLS. Can you briefly describe the data and the discussion that led to that recommendation?
There is a large placebo-controlled trial of oxycodone naloxone, mean dose of 20 milligrams, that was published in Lancet Neurology 7 years ago in patients with refractory RLS. It was much superior to placebo. There are other smaller randomized controlled trials that are older demonstrating efficacy. Most of the opioid prescriptions for RLS are for patients with augmented RLS or refractory RLS that doesn't respond to the first line treatments. There's really quite a bit of anecdotal evidence demonstrating their efficacy. I have a national registry of patients who are prescribed opioids in low doses, and I want to emphasize these medicines are used in very low doses in RLS, where we have followed patients, 95% of whom are not mine, across the US and some in Canada for 5 years, demonstrating that there is continued efficacy of these medicines at these low doses with very little dose increase over time. This is quite distinct from non-cancer pain, where we see opioid doses increasing and becoming less efficacious over time. This is a different mechanism of action. It certainly works through the mu opioid receptor, but downstream it's going to be different. And I understand people's concern and reluctance with this approach. However, patients with augmentation are really in terrible distress. These medications are effective at roughly 5 to 10% of the doses that are used in chronic pain or for opioid use disorder. Very low doses, methadone doses of 5 to 10 milligrams, buprenorphine, naloxone combinations like Suboxone doses of 0.25 to zero point 0.5 milligrams. Extremely low doses are effective for restless leg syndrome. So I think if people don't feel comfortable doing this, I understand, but then they should, rather than just increasing the dopamine agonist dose, refer them to someone who has experience with this opioid class of medications.
Excellent. Well, thank you so much for sharing your thoughts. I want to finish today by letting you, as a leader in this research space, give us your advice for the future. In a recent paper that you wrote with the International RLS Study Group, you mentioned the significant decline in research and development in the field of RLS in this decade compared to the last. You cite the hesitancy of pharmaceutical companies to develop new drugs when there are generic first line therapies available. Do you see these new guidelines as potentially resparking interest in research? And if so, can you provide guidance for our next steps?
That's a good question. I do see this as catalyzing research in the field because the dopamine agonists are generic, but I think that providers will increasingly shy away from using those medications given the long-term complications associated with their use. The gabapentinoids are generally generic, so that's one approach. There are new approaches that are being just in early stage development for restless leg syndrome, but really, I don't think funding is going to come from NIH. It never really has for restless leg syndrome. It's a little bit like the Rodney Dangerfield of medicine, or maybe even of neurology, that it just don't get no respect. But I think we're going to need to depend on pharmaceutical companies to lead the way here, to see an economic benefit, given how common clinically significant restless legs is. 2 to 3% of adults with clinically significant symptoms. And I think that will lead to some new approaches. We already have a transcutaneous electrical stimulation approach that has just been FDA cleared, a completely different approach, similar to TENS, that is used on the perineal nerve. And I think that this may provide a non-pharmacologic approach for some patients. So I do think we're going to see some creativities in this area moving forward.
This is wonderful. Thank you so much, John, for your time and for your insight on this topic.
It's been my pleasure, Karen. Thank you for trying to improve the lives of the millions of people with RLS.
That was Dr. John Winkelman of Massachusetts General Hospital and Harvard Medical School, interviewed by Dr. Kara Wyant of the University of Michigan. ANA Investigates is the official podcast of the American Neurological Association. The show's producers are members of the ANA Education Innovation Committee, chaired by Michelle Johansson. I'm Adeline Goss, podcast host and executive producer. Our production team this month included Kara Wyant and Jen Hurley. You can listen to past episodes of the show, subscribe to us so you never miss an episode, and access all of the ANA's educational programs on the Education tab at myana.org. That's it for ANA Investigates. See you next month.